So good afternoon, everyone. Welcome to our first webinar of our Postpartum Hemorrhage webinar series hosted by the Office of Lifelong Learning and the Physician Learning for Health program at the University of Alberta. My name is Denise Campbell-Scher. I'm the Associate Dean of the office. Our office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to addressing the challenges related to postpartum hemorrhage, which is the leading and most preventable cause of direct maternal mortality and morbidity globally and in Canada. So phase one is going to start today, and there's a three-part series. So we would really like to acknowledge that we are on the traditional territories across Canada of the many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. I'd like to kick us off with some housekeeping information. So on the bottom of the Zoom, please use the chat feature if you have questions about technical difficulties or L3 programs and services. If you have a question for the speakers in the webinar, please use the Q&A feature. Please review what's already been asked and upvote those questions you'd like answered. We can't guarantee that the panelists will be able to respond to all of your questions. A recording of the webinar and our Pearls document will be sent to all of you who registered via email. Participants can claim CME credits and complete a personal development activity using the My L3 Plan tool. For more information, please scan this QR code, which is also available on our Office of Lifelong Learning webpage. This activity has not been formally reviewed by the CFPC or Royal College. However, it is eligible for non-certified credit. MainPro Plus participants may also earn additional certified credits by completing a learning linking exercise. One of the physician learning program's goals is to improve delivery of care by supporting physicians and teams in data-driven quality improvement and responding to the needs of Albertans as they arise. We have a project ongoing that we'd like to invite anyone who's involved with the process of prescribing antimicrobial prophylaxis for obstetrical patients to participate in. So if you'd like to have more information about how you can support this initiative, please scan this QR code. We'd be really grateful to hear from you. So for today, we're very pleased to invite Dr. Cooper and Dr. DeVetten, who are going to be sharing with us the most recent information on postpartum hemorrhage risk identification and early treatment, and understand how the AHS Interprofessional PPH Toolkit can be used to help improve patient outcomes. So I'd like to start by introducing our speakers. Dr. Cooper is a Calgary-trained obstetrician and gynecologist and maternal fetal medicine specialist. She's an assistant clinical professor at the University of Calgary Cummings School of Medicine and the provincial knowledge lead for women's health for the Clinical Knowledge and Content Management Program from Alberta Health Services. She has over 15 years of experience caring for pregnancies with complications, as well as overseeing delivery of numerous beautiful babies at the Foothills Hospital. Her passion is in providing empathetic, comprehensive, evidence-based care that's individualized to each family and supports autonomy, collaboration, and respect. Dr. DeVetten is a family physician in Calgary with a special interest working in vulnerable populations and maternity care. She received her MD in family medicine residency from the University of Calgary and pursued extra training in tropical medicine with the Gorgas course in Lima, Peru. Dr. DeVetten is the prenatal lead at the Mosaic Refugee Health Clinic, and she also works at the Alex Youth Health Center and the Lougheed Maternity Group for maternal newborn care at the Peter Lougheed Center, and is helping to lead the new STAR program. So thank you very much to our speakers, and welcome to everyone. So pleased with the turnout today. So I'm going to turn it over to Dr. Cooper.
Hi there, everybody. Sorry, my ongoing IT issues. I'm like, how do I make all of that go away? Okay. Well, hopefully this will work. I'm really happy to have everybody joining. This is a topic that's really important to not just me, but to everybody who takes care of pregnant people, and not just during delivery, labor and delivery, but also in antenatal care. Whenever we talk about potential use of drugs in our medical management, is important to recognize conflict of interest, and I have no disclosures. I have previously received funding from a pharmaceutical company, but I did not take any of that personally. I donated it all to research and education fund. So, okay. So what I'm going to talk about today, some of you may have heard this before, is about this major amazing project or initiative that started as, a small group of people at the Foothills Hospital and has really now become policy and protocol in Alberta for the management of postpartum hemorrhage. And why it's important is that it really truly is the leading cause of maternal mortality worldwide, but more importantly, it's the most preventable cause of maternal mortality. And excuse me, more and more data is coming forth to say that, education is not enough. Me sitting here and just talking about postpartum hemorrhage is not enough to actually save our moms. However, data has, in big studies and well-published studies now, shown that large-scale quality improvement programs can reduce both morbidity and mortality. And so that's what this project is all about. And PPH has been increasing locally in Alberta, across Canada, and in many high-resource nations over the past couple of decades. And the interesting part about that is that it's not just due to cesarean sections, but the leading driver of that is due to atony. So what that means is that we can potentially prevent some of the very severe cases of postpartum hemorrhage, including those that require ICU admission and blood transfusions, by the way that we manage obstetrical care. So as I said, there's definitely not a trend that's unique to just Canada. This has been identified in the UK and Ireland, and what they recognized in their regular review program, which is a very robust program, is that the severity of postpartum hemorrhage was not recognized in, I really don't know how to make this thing go away, in 61% of women who died, the severity of the hemorrhage. So that is something, again, that and the US did similar reviews, and what they found when they looked at the cases from death due to obstetrical hemorrhage was that 93% of these deaths were potentially preventable, 93%. And the reason they said that was that upon their review and assessment, that was due to lack of appropriate attention to clinical signs of hemorrhage, and also failing to act to restore blood volume and make decisions that would save lives. So this idea of like, wow, we're denying that we actually have a problem, and as a result, we're delaying the treatment that will save lives. California similarly did a review looking at their pregnancy-related obstetrical hemorrhages in the early 2000s, and 76% they felt was a delayed response to clinical warning signs, as well as ineffective care, failure to consult, etc. So again, very common themes that are being seen internationally. California then took it a step further. They're like, we're not just going to look at the data. We're not just going to observe the problem. We're actually going to make change. And so they said, not only are we going to collect the data, we are also going to develop a large-scale QI program and collaboratives to actually address these issues. And their goal was to end preventable morbidity and mortality, as well as racial disparities in maternal care. And after they adopted this initiative, you can see the dramatic drop in maternal mortality in California compared to the increasing mortality in the rest of the United States. And California is not a small state. The population of California is pretty much the same as the population of all of Canada. So, we should not poo-poo this. The other theme that we have seen over the past couple of decades in medicine overall is the idea of these safety bundles. And again, not just in obstetrics, but the idea that sets of evidence-based practices, when performed consistently, improve outcomes. So doing things the right way and do them the same way each time by everybody in the team. And CMQCC, or the California Maternal Quality Care Collaborative, developed then something even further, which is a toolkit. So these are more practical documents or tools to use that they actually say, you know, these are customizable, use them, and please use them, and they're free. And you can actually, anybody who wants to check them out can see that, but you don't need to because you're going to see ours, that allow people so they don't have to reinvent the wheel. And, you know, when I started this project and many projects, everybody's like, well, just go to SOGC. They've got all the information there. And yeah, I mean, the information is there, but what it doesn't tell us is really how to do things from a multidisciplinary fashion, and have the practical sort of tools and the experience of actually, you know, using these tools in real life, seeing what works and what doesn't work. So these are the Steph safety bundles, which is the following, and I'll talk about how we then made these into an AHS toolkit. So one is assessing and identifying hemorrhage risk for every woman, and assessing and recognizing, assessing and treating PPH by stage, doing two things: measuring cumulative qualitative blood loss, or what we call the QBL, and using stage-based check sheets, meds, fluids, and escalation, and blood products, etc. And then the other side of that is debriefing after every PPH, using the idea of simulations and drills, especially in areas where this may not be common, and reporting and reviewing of adverse events from a bigger systems perspective. And remember, again, the whole goal of all of this is early identification of not just people at risk for PPH, but also those who are having a PPH, and having a standardized, timely response. So no denial and no delay. This is the PPH toolkit, which has been organized into the steps of change, including readiness, recognition, reporting systems, and response. And they are readily available for anybody who wants to see them. These will be changed as they get updated with new information, and there will be more added. And again, the idea is that these will be customizable as well. And you can find these through the Mincy Insight webpage, and also, or you can email aphp.edu@ahs.ca. Okay, so I'm just going to go through some of these principles quickly. I could talk about all of this for hours, but so the risk assessment allows early recognition of hemorrhage, allows increased surveillance, increased use of preventative measures, and initiates an early aggressive response to bleeding. However, we should be doing risk assessment antepartum. So if a patient has multiple risk factors, should we have a care plan? Should she be transferred to a higher acuity site? Can we optimize her blood volume so she has less morbidity if she does have a postpartum hemorrhage? And we are going to have a lovely presentation following me about use of iron to optimize hemoglobin entering into a delivery. The second part is here is to actually use a check sheet to look at what those risk factors are. And this is from our toolkit that actually guides management to say, okay, well, this is a low risk person. Well, we still recommend active management of this third stage, which is prophylactic oxytocin after delivery of the baby, and still measuring blood. But as we have higher risk people, we're going to have more strategies and preparation with the interdisciplinary team for when that patient does bleed. And back to the early recognition and response, you know, it was a big change for everybody. And there's lots of sites now, including Foothills, where we started this, changing our estimated blood loss to actually having objective measures of blood loss. Because without question, we know that visualization of blood loss, especially obstetrical blood loss, is very poor, and almost every study will show that blood loss has visual blood losses, people underestimate volume by sometimes more than 50%, especially as blood loss increases. Oops, sorry. And so what this means is that we are going to be doing this for anybody who is delivering a baby in Alberta. Is the idea that we are going to measure and report this, as well as to enter it into our Connect Care programs. And this is used, so you saw at the last slide, that's basically weighing sponges and other material like that, and as well as using clear calibrated drapes so that you can actually see visual recognition of how much a patient is bleeding and reporting that to the team. And back to our toolkit, you can actually see a little video about how you use that. Another concept I want to get is that even though it's really important to talk about the QBL and how much blood somebody has lost, people are different. Some people are going to start a pregnancy go into a delivery with adequate hemoglobin. Others are going to be anemic, different degrees of dehydration and different body sizes. So it's not just the blood loss itself, it's also the signs and symptoms, and to recognize the more softer signs of impending hypovolemic shock, looking at change in heartbeat and tachycardia, because often by the time someone drops their blood pressure, they have lost a significant amount of blood. And by the time somebody is, pale and decreased level of consciousness, it really truly means that we have sort of missed the opportunity to have intervened sooner. So some of these, the management of those scary PPHs are going to be talked about next week with Dr. Birch and Dr. Thompson, so stay tuned with that. But what we have developed as part of this initiative then is to actually be talking about the different stage. So, stage 1 being, more than expected blood loss, but normal vitals, versus the stage 3, the big bad scary PPHs. And you can see again the check sheets, and check sheets are something that has been well established in lots of areas for safety, such as the aviation industry, but also in medicine as well. And an example, of course, the safe surgical check sheets. So people will have this so that in an emergency situation, especially if it's the middle of the night and it's unusual, then people are not trying to just think about what they should do or what they're supposed to do or what they learned at this webinar. They actually have it in front of them. And, it was, again, a big change for people to get on board with the idea of these check sheets. But I refer to ACOG, or the American College of Obstetrics and Gynecology, where they clearly say that protocols and check sheets have been shown to reduce harm and improve outcomes in medical care. So it's not supposed to be cookie cutter medicine or cookbook medicine. It's supposed to be a guide. And of course, clinical judgment can be added to that and individualization, but to have this sort of a set guide to begin with. So for example, the stage 1 PPH check sheet, it's about measuring blood loss, using medications appropriately, warm blankets, and reporting blood loss and cumulative blood loss. We include the medications, and there was a lot of time spent reviewing what is the best medications, and a couple of things that might be changing, practice changing for people. So really a focus on giving oxytocin prophylactically with all deliveries, and 10 milliunits IM for low risk people. If you already have an IV, you can use an infusion, or you can do a slow 3 units, a slow over 60 seconds bolus. And for high risk vaginal deliveries, you can use carbetocin as well, and that's going to be used in cesarean sections. You'll notice for first line treatment of PPH, we have oxytocin infusion, and a second line is ergonavine. And it's a bit different than SOGC, and everybody's like, you should do what SOGC says. But, this is based on, again, not just our multidisciplinary discussions and actual clinical practice experience, but also on simulations. And why we say ergonavine is that it works really well, and recognizing this is for atony, for which the majority of postpartum hemorrhages are. It is very safe. It had a really bad rap in the past, and I think it's taken a while for people to recover from that. But if someone has, preeclampsia or significant hypertension, no, we don't want to give that medication, but short of that, it's a really good and less side effects than carboprost or hemobrate. So misoprostol should not be first line. It takes a lot longer than the other medications to work, and rectal administration actually is far inferior to oral administration. So if you're going to give misoprostol because you want to do everything all at once, or while you're trying to get an extra IV line or whatnot, then do give it orally. And the reason why TXA is not in first line is because I don't want people to delay giving ergonovine because they're trying to give TXA, but they're also then using their IV where they should be giving oxytocin or spending time trying to get a second IV. So if you want to give ergonovine and do TXA at the same time, you can, but this is sort of based on practical information. Some other parts of the check sheets and stage-based management are available, like bimanual massage, and a lot of this that we're getting to as we talk about the stage 2 PPHs. Again, a video out of Toronto that is very clear and about using intrauterine compression balloon. And then next week, the really scary stuff is going to be presented by Dr. Birch and Dr. Thompson, so stay tuned. So just to move ahead, I know we have limited time. The importance of debriefing after every PPH, because that's where we learn from experience and reinforce all that went well, but also find system issues that we could fix. It's not supposed to be a shame blame type of I guess, approach, but really the idea that if somebody makes a mistake, that anybody could make that mistake, and how do we fix the system to support everybody who's caring for our patients, but also to hear our patients' perspective from postpartum hemorrhage management. And next week, in 2 weeks, we'll also have a patient's experience and learn from them together about what we did well and what we could do better. The importance of regular simulations and drills, especially if you're in a location where postpartum hemorrhage is not common. And we actually went up to Peace River a year ago to test the tools in a level 1 site, worked directly with teams who are providing rural maternity care, and it was exceptionally valuable from my perspective. And we also include eSIM and human factors support. And yeah, it was absolutely fantastic. And you'll hear a little bit more about that from one of the Peace River team, Jacqueline, who's the CNE, who's down there in the little picture next to me, and we'll have great perspective there. The importance of reviewing and reporting adverse events. We're not great on a national perspective the way that the UK is about reviewing maternal deaths, let alone the severe maternal morbidities. And depending on which study you look at, there could be, for every maternal death, there is 9 almost deaths, or up to 30 or 40, depending on which study you look at. So we really do need to have a better process for review of the near misses, and that is something that Dr. Philippa Brain has been devoting her time and energy, and she'll be talking about that on the December 21st webinar as well. So it's a lot of change for people. I get that. And change is hard and everybody's exhausted. And that's why we have the toolkit for you. And there's been people really working hard behind the scenes to make this as easy as possible as this practice transition occurs. But I really, as one of the feedback is as well, yeah, does it really work? Why are we doing this? Wait for more data, wait for more data. But, again, back to California, same population as Canada. So when they compared hospitals that adopted the toolkit, which is similar to ours, they had a 21% decrease in near deaths from maternal bleeding in the first year compared to 1.2% in non-adopters. And we know it works because after less than a decade, they were able to show a significant reduction in maternal deaths. And this has also been reinforced in studies in medium resource hospitals in 2023 that basically says the same thing: adoption of a safety bundle, including QBL and an escalation protocol, significantly reduced outcome of severe PPH, laparotomy, and death. And in Alberta, what is our postpartum hemorrhage rate? Well, it's 12%. And, Dr. will talk about the dashboard and actually using our lovely Connect Care to actually be able to keep track of trends in not just postpartum hemorrhage, but other maternal emergencies and morbidities. What we did see locally is that we have had an increase in postpartum hemorrhage, but sort of around the time we started our project, we started to see a decrease in the number of postpartum hemorrhages where they required transfusion or transfer to a higher level of care like the ICU. And then when we did give blood transfusions, that it was it was more appropriate use of red blood cells. We didn't call up blood that we didn't use. And we actually, I thought we would, as part of the principles is the use of red blood cell transfusion. And I assumed that in our, preliminary data that we would see more blood transfused, but we actually saw less. That meant we treated atony better. So this is all fantastic news. This works, and it can be adopted by teams, and we can do better. And we are unique in Alberta. No other province has done this, and no other province has the ability to do it together and to have the ability to look at our outcomes through computer database and adjust those to improve the care for our patients. So again, just a couple of, as part of the provincial implementation, access to resource. And thank you to the amazing teams over the past 5 years who have been working really hard to make this live and make this ready for everybody in 2024. And with that, I am going to stop. Again, I could talk about this for hours, and hand off to my next speaker, who is going to focus on optimization of hemoglobin in the antepartum period to reduce the morbidity related to postpartum hemorrhage. So I'm so happy that Giselle is joining us. I'm going to pronounce your last name, DeVetten. Wrong, so she's going to say it right. Okay. All right. I'm going to unshare. Thank you, everybody.
Hi, everyone. Thanks, Steph. Hard to go after you because you are such a good speaker. So I'll do my best. Let me know if there's any concerns here. Again, hi to, there's so many people here. It's a bit overwhelming. So again, I'm Giselle DeVetten. So I am a family doc in Calgary, and I am not a hematologist. I am not an expert in iron B12 deficiency, but I can tell you that I have spent years learning about it and putting in lots of effort to improve anemia rates for my patients, and trying to give our patients the best outcomes that we can, and then also trying to disseminate the knowledge across the province so that all of the patients have access to this. So the goal is to update everybody here and healthcare providers on anemia, B12, and iron deficiency, and to teach people how to properly replete the iron and B12 stores, because for so long we were not doing it properly. I have no disclosures, unfortunately. All right, so why do we care? So I may be preaching to the choir for some of this with iron deficiency anemia, but B12 deficiency might be new to many people. So iron deficiency anemia can lead to so many things for the mom: fatigue, mood concerns, and then obviously problems in the pregnancy. It can actually increase your risk of C-section and blood transfusion, which we know about the blood transfusion. But for the poor babies, they can end up with iron deficiency and anemia and potential long-term issues. Anemia is actually the most common indirect cause of adverse maternal outcomes. PPH is obviously a huge adverse effect, an adverse maternal outcome, but anemia is an indirect cause and can lead to all these other things. And postpartum, it can lead to postpartum depression. B12 deficiency, though, can lead to fatigue, which is a super common complaint in pregnancy, but neural tube defects, in addition to the folate deficiency, it can lead to problems for the baby. And so preterm delivery, SGA infections, but the biggest thing is that these babies that are born to moms with really bad B12 deficiency can have potential cognitive issues, but developmental aggressions, but neurological issues. So there are people across the country that are looking, and across the world, looking at B12 deficiency in pregnancy. So I'm going to start with 2 cases and let you know about them. And these are actually not that uncommon. They're a little bit more complicated cases, but they're pretty common that we see at our prenatal clinic in Northeast Calgary. So Zainab is a lovely 22-year-old primate, almost 32 weeks, who presented for her first prenatal at a maternity clinic. Prior to coming to our clinic, she was seeing walk-in clinics. She's a newcomer, only speaks Somali with minimal supports. She denies being a vegetarian, which is great. So her biggest complaint was that she was so dizzy and tired when she walks too long. So the whole visit was very complicated because she also had FGM and other complaints. And then she had a new diagnosis of GDM that I had to tell her about. But I knew one of the biggest things that could impact her pregnancy at this moment was her hemoglobin of 87. and her ferritin of 7, and that was done weeks ago. So her ferritin hadn't gone down at all, but either probably because she was taking some Ferromax that was prescribed to her by her walk-in clinic doc. So we'll come back to her. Kiranjeet, so also a lovely 26-year-old Punjabi primate, first visit at 19 weeks, speaks English, and also not a vegetarian, but doesn't eat red meat. So pregnancy was pretty uneventful, but if you look at her hemoglobin, she's anemic, and her MCV is quite low. So I didn't put the MCV at the last case because it wasn't significant. So this one's low. Ferritin was okay, and the B12 wasn't done. So we'll come back to all these and you'll learn so much, hopefully. So I want you guys to all remember this, these definitions. So these are based off of the WHO and NADA guidelines, except for the B12 deficiency I'll explain. So anemia in pregnancy diagnosis is a hemoglobin less than 110. So we don't want to use anything higher because there are hemodilution effects that occur in pregnancy. Iron deficiency is a ferritin less than 30. And that's really important because most labs in APL will report iron deficiency is a ferritin less than, I think, 16 or 17. But in pregnancy, because you need more iron and the baby takes all of your iron stores, we're using a less than 30 for ferritin, and that's approved worldwide by like NADA guidelines, et cetera. And then iron deficiency anemia, severe IDA, and then vitamin B12 deficiency is a funny one. And I've been doing a bunch of research on this for the last couple of years. There are no international guidelines on vitamin B12. Serum vitamin B12 levels change per trimester in pregnancy, just like a TSH would because of the different binding proteins. There are no guidelines on what are normals in each trimester, and most labs will say B12 deficiency is less than 170-ish, but a lot of people will say borderline is up to 220, but given pregnancy, given all the complications, and given the fact that there is no standardization of what varying values would be in pregnancy, we're going to use a higher value to prevent any possible issues for baby. As Steph said, blood transfusions, not benign, not always better, and there's a risk of alloimmunization, so which is not good if you're going to plan on having more babies. So at the PLC, this is, I mean, hopefully we can get actual numbers, but we've decreased our blood transfusion rate after we started doing the implementation of proper iron prescriptions, IV iron, versus we haven't started our quantitative blood loss yet program, but so it's pretty cool that we've already done that with just decreasing blood transfusions. All right, so this algorithm I created with Dr. Bella Lewis and pharmacists through the drug stewardship team, as well as other physicians in 2019, like just before the pandemic. So it was mostly just rolled out at the Peter Lougheed because that's where Val and I work. And then we've updated it recently in 2023. And I'm working really hard to try and get this out to as many people as possible in Alberta. So one of the biggest things, takeaways from here, is doing a CBC and ferritin with your first prenatal labs and then repeating that. So a lot of people never do a ferritin and a lot of people don't repeat it. And then adding B12 here. So this is my disclaimer. The B12 stuff in this talk is based on all the research I have done and the potential guideline I'm hoping to create. It hasn't been finalized, and I think in the actual algorithm online, it's B12 deficiency is also defined as like less than 175 picomoles per liter. But here I just put a little thing over top that says less than 220. And I'm going to give you more parameters for when to test for B12, but I'll do that later. So we'll focus on iron first. So hopefully it's quite straightforward. You know, left is normal, iron deficient, and then IDA, and then severe IDA, and then anemia is where your friendly hematologist is your friend. And we'll talk about that. And then basically you want to treat someone if they have iron deficiency or iron deficiency anemia, because if they have iron deficiency and they're not anemic and you don't treat them or you don't pick it up because you didn't do the ferritin, next time you do their blood test, they're going to have iron deficiency anemia because those babies just take up all that iron. Okay, so in brief, if you have someone that has weird anemia with that iron deficiency, check for a whole bunch of these things. I see a lot of H. pylori, I see a lot of hemoglobinopathies, and a lot of people with hemoglobinopathy will never reach an HB of 120, okay? All right, so this beautiful slide, you don't have to know any of it except for hepcidin, which is a really cool protein. I think it was discovered in 2004, first described. And the reason why it's so important is it's changed the way that we treat iron deficiency. So hepcidin is a protein that if you give someone a big iron load, like a pill, medication, etc., the hepcidin will increase. So once the hepcidin is high, it will downregulate iron transporters, and then you cannot absorb any other iron in your system. And so, for example, like when we used to treat people with BID and TID iron, the second and third doses were just staying in those people's GI tracts and causing the symptoms of nausea, constipation, all those fun things that people don't want to have, especially in pregnancy. And so hepcidin has really changed that, which is hepcidin can stay elevated after an iron load for up to 24 to 48 hours, which is why daily or every other daily dosing is what is recommended. And then it also is slightly lower in the morning, which is why we also recommend morning doses of iron. All right, so again, just to repeat, so this is how I would give someone an iron prescription. Here's your iron prescription, 30 days with refills. Don't forget the refills. You can either take it every day, but I usually recommend everyone to start with intermittent, so every second day. Sometimes I say Monday, Wednesday, Friday if the person looks very confused about every second day. And then I say in the morning on an empty stomach, no meds, specifically no prenatal vitamins, nothing with calcium, no coffee, no dairy, nothing with the 2+ cation that can interfere with the absorption. The type of iron, I give a ferrous salt. I specifically give ferrous fumarate because it has 100 milligrams of elemental iron in it, whereas the other ones have slightly lower. The polysaccharide irons, Veramax, etc. They're great. A lot of people like them because you take them daily. You don't have a lot of side effects, but because the elemental iron is like so low in them. So you will improve your iron stores, but it takes a long time. When you're pregnant, you have a finite amount of time until you, like when you need to have a better hemoglobin because you're having a baby. So ferrous fumarate, that's my go-to because it's really straightforward. It's 100 milligrams of elemental iron. And then especially with my newcomer population, I do a lot of describing of like, this is the prescription for 30 days because I want to see how you tolerate it. Then there's refills. So you'll have to take it for your whole pregnancy and for at least 6 weeks after. And the reason why I do that is you might be surprised at how many people don't understand refills. Okay, so just explaining that. And then I have some patients still don't tolerate it, but people tolerate it iron way more than they used to. I don't know, I've been practicing for almost 10 years. So the way that we prescribe it now, it's like probably 85 to 90% of people tolerate it. And if they can't, then I say take it with a piece of fruit or some bread, anything but dairy in the morning, or take it at nighttime and see if you can tolerate it. If you can't, I usually prescribe ferrous sulfate because it has a lower elemental iron. And then if that doesn't work, then I talk about IV iron. So again, here's the algorithm. So now you're at the bottom here, giving people oral iron. And then it says assess oral compliance. So that's the biggest thing is years ago, I would prescribe iron and just never follow up with it, which, sorry, that I guess I wasn't a very good doctor at that time. But now that I'm following up with people, it's so amazing the things that you learn. People were taking it incorrectly. They weren't taking it at all. They stopped taking it after 30 days, et cetera, et cetera. So now we're making sure people are taking it properly and helping to fix how they take it. And then we repeat CBC and ferritin in 4 weeks after they have proper oral iron intake. And we evaluate the clinical response. So this is one of the changes in 2023 is that initially we just said, give IV iron if not responding. And now it's like, well, are they 12 weeks and then 16 weeks? They've responded just a little bit, but not a lot. You have 20 more weeks to improve their iron stores. You don't need to go right to the big guns of IV iron. And so it's just allowing people to use their brains and clinical response to like come up with what they want to do with their patients. So it's not as intense. And then we also added this slide on the left, how to take oral iron and the equivalencies of elemental iron. All right. So the website I'm going to give you at the end here for these, the therapeutic backgrounders, the algorithms, also has this really nice PDF on iron dosing administration. The ferrous salts are dirt cheap, cost people nothing. All right, and follow up, like I said, ask. All right, so when to give IV iron? You want to give IV iron for someone who has severe anemia, someone who you diagnose at greater than 34 weeks, which is really common in my refugee population because they arrive so late. If they fail the correct trial of oral iron, they can't tolerate it or they can't absorb because of whatever reason. I use iron sucrose. That's what most of us use, 300 milligrams IV, given over 90 to 120 minutes. And you can give it every 3 to 7 days. Most patients, there's a Ganz-Only formula here. You can calculate how much they need, how many milligrams of iron. but most people will need 3 bags. Monoferric, this one, it's actually in our little algorithm, but it's not, I need to let you know, it's not approved for pregnancy, and it's not covered under the formulary. However, there's a lot of people working on this because it would be much cheaper to give this because it's 1,000 milligrams, and it's given over an IV push, basically. So it'd save the system more money. People are giving it across the country, so like I don't think there's no major concerns, but I'm not going to promote it or not promote it today. All right, and then here's the cost of the Venofer versus Monoferric. Okay, and so whenever I tell someone about IV iron, I get them to sign a consent form. I basically tell them it's really rare to have a severe reaction, less than 1 in 200,000. And they're so much better than like 10 years ago with the different formulations. And if you have a reaction, it'd more likely be like a rash, tummy pain, nausea, dizziness, and then we stop the infusion, give you some medications. And if you want to, we can restart it at a slower dose and it's usually fine, and then pre-medicate the next time. Ordering IV iron is very different depending on where you are. It's gotten a little bit better with Connect Care. And so in Calgary, you need privileges and you need to do it at a day medicine site. Oh yes, do not use it in first trimester. There's no safety data, but most of the time you wouldn't need to anyway, because you should be starting with oral iron first trimester. Iron does make a difference. We need more studies to show this. It's common sense that if you're not anemic and your iron stores are replete, if you have a PPH, you're going to have a better outcome. You're going to have less postpartum depression. It's just, they haven't done a ton of studies. Iron is not sexy and there's not that much money out there, but anecdotally, I get lots of good outcomes from it. So, all right. And so postpartum, don't forget, like some people might be great with their iron levels in pregnancy, but then after they have a big bleed, we give either 1 dose of IV iron, or we can continue their oral iron to prevent any of these concerns. The biggest one is depression, cognitive issues, and then the interactions with baby. But there isn't a ton of great evidence about this either. Vitamin B12. Okay, vitamin B12, this is my new favorite topic. So this is how we are practicing at my clinic, both my clinics in Calgary. We're adding vitamin B12 to initial or 24-week labs, depending on where you see the patient. If they're vegan or vegetarian, that's like standard for everybody. But if you're a really good vegan or vegetarian and you eat certain foods, your vitamin B12 will be fine. If you're a newcomer or a refugee, like it's astonishing how poor some of the nutritional intake is and how low the vitamin B12 levels are. My Indigenous people, even though they're eating meat, there's a lot of B12 deficiency. South Asian and Punjabi, it is also interesting. A lot of them are vegetarians, but then you get some that aren't vegetarians and they still have B12 deficiency. PPIs or metformins can interfere with B12 absorption. Anyone that has a previous B12 deficiency, and then anyone with substance use, because of their poor nutritional intake, you should be testing for B12. And then the treatment of B12 is so simple and straightforward in comparison to iron. Iron is this high maintenance medication. B12, you can just throw anything at patients and they will do better. So most of my patients, I just give 1,000 micrograms daily, and the B12 absorption is kind of complicated in the gut, but if you just slam a lot in the gut, it'll like absorb through the blood and step through all those funny receptors and etc. And you don't have to give them IM anymore. Like that's what we used to think, but a lot of studies show that if you give them this high dose oral versus IM, it's the same, and it's much cheaper to give them oral and a lot more like acceptable to patients. I reserve IM for my refugees that come at 34 weeks and their B12s are less than 100, and they're coming every week anyway for their visits, and we just give them the injections. There are also sublingual and intranasal formulations. I don't know a lot about them because I don't use them and they're probably more expensive, but I think those are also good. Quick plug, we're trying to publish a study. Basically, we did a retrospective cohort study of our pregnant women, and we found a 43% prevalence rate of vitamin B12 deficiency, which is huge. We also found obviously a large anemic rate in iron deficiency. And one of the reasons why we're doing this is that people often think that you just test B12 deficiency in people that have macrocytosis, neurological symptoms, or vegan or vegetarian, but there was like none of our patients had macrocytosis because they were all either thalassemia traits or iron deficiency. All right, so let's do the 2 cases and then I'm done. I think we're like doing good for time. All right, so case Zainab. So our lovely Somali girl who didn't speak English. So we gave her 3 doses of IV iron within the first one within a week of seeing her. And then after we got some extra labs, we started her on B12 supplementation. So if you look at her labs, so basically I think that day or the day after I saw her, July 20th, her hemoglobin had dropped to 81. Her ferritin was only 9 and her B12 was 139. So even if you use a definition of 176 for your B12 deficiency, she was deficient. So, and then fast forward to 38 weeks, holy moly, she went up from 81 to 119 with 3 IV iron infusions and vitamin B12 every day. Her ferritin was amazing. Her ferritin was amazing and her vitamin B12 was amazing. And it was just so lucky that I was in the hospital when she came in labor, and she looked at me and she's like, thank you so much for helping me with the iron. And she's like, I'm feeling so much better. And so that was pretty rewarding for me. But also I love looking at these really great numbers. Kiranji, our lovely Punjabi girl. So her hemoglobinopathy screen came back as beta thal trait, which is usually more severe anemia than alpha thal. Her husband was negative, which is good for baby. So we started, because she was only 19 weeks, even though she was quite low, we started her on ferrous fumarate every other day and then vitamin B12. And so as you can see as well, her hemoglobin slowly increased. Her ferritin kind of stayed the same, but her B12 improved quite a lot. And so she told the doctor, I actually never saw her, but she told my colleagues that this at 39 weeks, this is the best I've ever felt. And what kind of person says that at 39 weeks pregnancy to say, this is the best hemoglobin I've ever had? And it's because we paid a lot of attention to her iron and vitamin B12. And so I'm hopeful that now that she's had her baby, that she will continue to get some regular blood work to make sure that she's optimized. And she will never, 110 will probably be one of her better numbers ever because of her beta thal trait. But anyway, I thought that was really cute that she said that. So vitamin B12 and iron can really make a big difference. I want to thank everybody, the drug stewardship team, my team members, all the clinics and all the people helping me. And then I have a ton of references. And at the bottom here is that website. You can also just look up drug stewardship, AHS, and it should come up. And there's a bunch of other ones with chronic kidney disease and other stuff that they looked at IV iron for. And I think that's it. So I hope I didn't talk too quickly. Anyway, thank you.
Fantastic. Thank you, Dr. DeVetten. Thank you, Dr. Cooper. Lots of information, but just to reassure the people who came late, everyone, you're going to get a copy of the Pearls document with these curated references from the speakers and a copy of the recording. So even if there's stuff that was passed that you're like, oh my gosh, I didn't catch it, it's there. So, so thanks for all the info. We have a lot of questions that are in the chat or in the Q&A. So just starting with Chihiro Reimer's question for Dr. DeVetten, just wondering about how accessible IV iron is for patients who need it. So you referred to the logistics in Calgary and whether it's covered, and a question about the use of iron fish, which I don't know what that means.
Yeah. Okay. So actually, this is so funny because there was a talk at Comms, and someone asked about the iron fish, and I didn't really know anything about it. But the iron fish is basically it's something you cook with that has a lot of iron in it. So yeah, that's totally fine. You can use it, but it's just not. It's hard to evaluate how much iron they're getting. So if people are adamant, I do have some people that don't want to take iron, and then we refer to dietitians, etc. But you can use it because the what is it called? What's the type of cast iron? The cast iron pans. A lot of people use that, and they can get iron from that. And so I'm just looking. I can read the questions too, Denise.
Sure. Yeah. I think Julie's got some questions around monoferric, saying it was covered in Ontario, but not benefit on the provincial plan, so the hospital won't give it. So it sounds like a bit of a furball.
Yeah, it's pretty frustrating. So you can ask Dr. Cooper, Dr. Brain, Dr. Lewis, a ton of people, and Dr. Simrit Brar. A lot of us are looking into it. There are hospitals, I think it's high level. They're already using it for a lot of their pregnant women. I think, don't quote me, I can't remember. They emailed me about it last year. Steph, if you want to bring it up, but it's such a pain that we can't use it.
Yeah, it's not with monoferric.
Yeah,
Sorry, Zoe. Yeah. Yeah. I know that there is, if you have federal funding, then you can access it. So, uh, Indigenous people with status can actually have it funded. But otherwise, yeah, I mean, it's trying to get change is so hard from a
well, and
perspective.
it's siloed, right? So
Yeah.
the pharmacy bill is siloed from the hospital
Yeah.
bill of like coming to get your infusions. And so hopefully at some point it'll improve, but I don't know when. So, but it's in the works and people are still using it. So if you want to be, because like my refugees should be covered for it, as are my Indigenous patients. And it might be covered under Alberta Works, but I'm not sure. So I just haven't gotten around to doing it yet. Have you, Dr. Cooper? Have you used it yet?
No, no, I haven't. But I know that there are people, one of the CNEs up north has been able to use it because she's a large Indigenous population. But so I don't even know too, you said in the private clinics, people can get monopheric if they have insurance. Okay, it's good to know.
But AHS said they would, the day medicine clinics would give it to people, but if they brought it in themselves. So you'd have to prescribe it and they can walk in and do it. I'm just anticipating I'm going to have a lot of phone calls about like, is this safe in pregnancy and a lot of things.
Yeah.
And I don't know. Okay, I can see. Oh, hi, Allison. Thank you for your talk. Did you test Somalian women for schisto? I think I did. Yeah, I did schisto and strongyloides, which is what we always do for our refugees. And then I would have asked her about H. pylori. I would have asked her about hookworm is a really, like, I mean, hookworm, you normally have blood in your stool. So we would ask about all these weird and wonderful things. Does hepcidin levels, do they change with trimester? I don't know. I don't know the answer to that, but that's an interesting one. I wonder if they do, because so many things change with trimesters with protein. So that's a really interesting one. Repeating ferritin with third trimester labs. So I would only repeat. So can you speak to the evidence to support repeating ferritin with third trimester labs? If the threshold to treat is less than 30, I'd be supplementing all my patients. That's a good point. So if you have like a Caucasian woman who eats meat and then you're doing she did her second trimester labs at 26 weeks and her ferritin was 40 and her hemoglobin was 115, I wouldn't even repeat it in third trimester. Like I wouldn't repeat it. And those people, even if she does bleed, unless she has a large bleed, because everyone bleeds a little bit when they have a baby, it should just go back to normal with her diet. So I wouldn't worry about it. But if you are testing for something else, for some other reason, it's less than 30, there's no harm to give her a little bit of iron, but I'm mostly concerned about less than 30 with anemia in like late third trimester. So you could.
Giselle, so I think part of it, that the comment is that we've moved, and I think a lot of people in Alberta have moved to routinely doing a ferritin at the time of the GDM screen.
Yeah.
Versus like, yeah. Late second trimester, but there's many jurisdictions that don't do that. And so even what is the evidence of that? So I think Janelle was just saying, in Northwest Territories, they're not recommending that people do a ferritin at that time.
Yeah, so I recommend, because of how the body changes, I would recommend doing ferritin and CBC in late second trimester, but I wouldn't, if it's normal then, I wouldn't do it again third trimester just to screen.
Right, correct. Yeah. I think it's important for people though to recognize that the added cost of adding a ferritin at the time of when they already have blood work for CBC and GDM, it's like, I think 70 cents, something like ridiculously cheap. So not to see, we all are trying to, adhere to choosing wisely and the idea of not doing unnecessary tests, but, given the cost, if you are already doing routine blood work.
And it's the same, your blood tubes, it's the same tube as the GDM screening, so you're not collecting more blood. And that's what I like to remind people. If you have thalassemia, what level of iron do you give iron? Ferritin. That one's hard. So if you saw that patient wasn't actually considered iron deficient at the ferritin of 30, but because she was so anemic, we probably should have done iron studies on her, but you have to do those fasting. And so we just started to replete her. And then if you can tell, like, her ferritin never actually improved very much, but her hemoglobin did. So I don't know if I fully trust ferritin levels in thalassemia, but that's something for like Val and I were going to look into and talk to some hematologists about. So hopefully I'll have better information next time I talk. Iron bisglycinate. I don't know what that is. Is that one of the new iron bisglycinates, Taryn? It's probably similar to like Fermax and the polysaccharides, and they're all just low. It's a new thing, a new drug that pharmaceutical companies get money for, and so they're going to be marketed really well. And so I just go with the ferrous salts because they're dirt cheap.
There's a question about, would you prescribe heme iron for iron deficiency in the same manner? So would you do the every other day?
I do daily then with the polysaccharides. And then I only usually do it if it's just a little bit low and it's early on. So because it won't, like, sure, if you took that for 6 months, it would improve. But if you're getting diagnosed at 28 weeks, that's not enough time.
Awesome. Okay, folks, there's a couple more minutes for questions. So it's 12:55. So feel free to pop a couple in the box. I think, Andrea, if you want to stick the eval up as well, because we really appreciate folks' feedback. If people could share. Elisa's got a question in there around midwives prescribing iron IV, maybe someday administering it in clinic.
So IV iron, yes, I know. I've had lots of midwife friends, and I've had to, as Dr. Cooper, and we have to help them get IV iron. I don't know. It's something to bring up with your midwife leadership team so that you guys can do it and you guys have good guidelines around it, because it's really unfortunate if your people can't access it. But the other problem with IV iron is that day medicine is a huge wait. And so some of our patients, if it's more than a 4-week wait or they're in late third trimester, our triages are doing it. So we book them for IV iron in our triage, but we need to do it smart. So because we don't want to overload our triage with people that don't actually need IV iron. And that's why there's like a balance of like healthcare delivery and dollars. And but anyway, I don't know. I hope midwives can order it. But if you cannot, just find a family doctor or an OB in your community that you can consult. And it's really not that hard for us to order it.
Jenny made a comment under chat that's relevant around, she believes there's a program at the Rocky View General Hospital now for midwives.
Mm-hmm.
So just that's under the chat box. And another colleague is asking, do you know anything about the efficacy and safety of using yellow dock herb for improving iron absorption?
No clue. I don't know what that is. If you can elaborate.
So just whoever was asking that, if you could elaborate on that, that would be fantastic.
While they're typing in, we recognize, this was rushed in a sense in that it's a short period of time with questions to present the material, and I do apologize. I could again talk a lot longer on this than I have for that area. So I do hope people do check out the recordings and the resources as well.
Yeah, no, so much information. Looking so forward to the next 2 webinars. So I think folks have clinic, so we should probably just extend our thanks to Dr. DeVetten and Dr. Cooper for a fantastic presentation. I enjoyed it thoroughly. I just have a question on actually iron dosing in my patients who are not pregnant. Is it still the same thing with this new daily dosing? That's a big practice change for me.
Yeah, I know it's huge. And there's still so many people that aren't aware of it. And if you go on Up to Date, I think they finally changed it, because they used to say possibly recommending daily or every other day dosing, and they still had the BID, TID dosing in Up to Date for the longest time. But yeah, and everyone, children are a bit funny because you only can give so much with liquid, but with adults, definitely daily or every other day, not more than that. You're just going to get more side effects and people are going to be mad and constipated.
Awesome. Well, we have one last question that snuck in under the chats, guys, that was interested. Kirsten was saying, I had a pregnant lady diagnosed with beta thalatrate. The hematologist said they wanted the ferritin around 100. And I'm a midwife. I haven't had issue at FMC and RGH. It sounds like they're going, that the commenting on logistics have been good. So that's interesting with the beta thalassemia, and always great to dial in our colleagues in hematology if there's questions. So I'm sure everybody's saying thank you. Look forward to seeing everybody next time, and have a fantastic afternoon.